The autumn rain pelted against the windows of Pacific Northwest Medical Center like tiny fists demanding entry, the rhythmic drumming almost drowning out the controlled chaos of the emergency department. Dr. Maya Chen stood in the staff lounge, clutching a steaming cup of coffee that had long gone cold, watching raindrops race down the glass while the hospital's fluorescent lights cast everything in that clinical blue-white glow that made even the healthiest people look ill. Before we jump back in, tell us where you're tuning in from. And if this story touches you, make sure you're subscribed, because tomorrow I've saved something extra special for you. At 36, she had the kind of quiet resilience that came from years of fighting to be heard in rooms where everyone else seemed to have a louder voice. Her black hair was pulled back in a practical bun, dark eyes that missed nothing behind simple wire-framed glasses, and the perpetual slight furrow between. Her brows that spoke of someone who thought deeply before speaking. She wore standard-issue surgical scrubs beneath her white coat, the name tag identifying her as Maya Chen, MD Trauma Surgery, slightly askew from her last emergency procedure. To anyone passing by, she looked like just another overworked surgeon taking a rare moment of respite between cases. Maybe contemplating test results. Maybe mentally rehearsing a difficult procedure. Maybe nothing more complicated than trying to remember the last time she'd slept more than 4 consecutive hours. But Maya wasn't here by choice. She was here because the hospital ethics committee had called an emergency meeting to discuss her emotional decision-making during last week's multi-car accident, which had triggered a formal review of her surgical privileges, which had led to a temporary reassignment to supervised cases only, which had somehow resulted in her being passed over for the trauma department leadership position she'd been working toward for 5 years. The kind of professional cascade that could derail a career if you weren't careful. This was her 4th encounter with hospital administration in the past 3 months. First, the chief of surgery had pulled her aside after she'd shed tears while informing a family of their child's death. Then the HR director who'd mentioned concerns about emotional stability in high-pressure situations after she'd raised her voice during a particularly chaotic trauma case. Then the peer review board where a colleague had described her as passionate to a fault, the kind of backhanded compliment that somehow became a permanent part of your professional reputation. Each meeting had generated more scrutiny, more observations, more opportunities for others to interpret her intensity as instability. She'd driven through pouring rain from her apartment downtown, a modest 1-bedroom where she'd crashed for barely 4 hours, after a 36-hour shift before being summoned back to the hospital. It wasn't much, but it was close to work, and proximity had become the most valuable thing in her life. The hospital administration wing occupied the entire 5th floor, its gray carpeting and beige walls creating an atmosphere of deliberate neutrality. The morning air carried the sharp antiseptic smell that permeated every hospital, mixed with coffee from the nearby nurses' station and that particular scent of administrative spaces, printer toner, air freshener, and the lingering tension of countless difficult conversations. Maya stepped into the ethics committee meeting deliberately, her movements calculated. She had that economy of motion that comes from years in the OR, where every gesture must be precise, every action purposeful. She checked her phone once, slipped it into her white coat pocket, and pulled a tablet from her bag. The tablet contained her surgical logs and case notes, documenting decisions that should have been straightforward to defend, but had somehow become a professional minefield. The committee room smelled like sanitizer and stale coffee, despite the air purifiers humming quietly in each corner. Fluorescent lights buzzed overhead, casting everyone in that institutional bluish glow that made senior physicians look ancient and junior ones look terrified. Behind the conference table, Dr. William Harrington, head of the ethics committee, was reviewing her case file while simultaneously fielding texts from attending physicians, who clearly didn't understand that he couldn't solve their scheduling problems during a formal review. Dr. Chen, Harrington looked up as Maya approached, his expression already sliding into that professional distance administrators perfected after their first decade. Maya placed her tablet on the table, noting how Harrington's eyes briefly took in her appearance. The slight dishevelment of someone who'd been called in during her first real break in days. The lack of makeup, the general air of someone who prioritized patient care over politics. "I'm here for the ethics review. Trauma case from last Tuesday. Multiple vehicle accident." Harrington's fingers moved across his tablet with practiced efficiency, pulling up files while keeping half his attention on Maya and half on the messages that kept appearing on his screen. "Dr. Chen, it says here you countermanded attending. Physician orders. Administered treatment against departmental protocol. The trauma director has serious concerns." The words hung in the air between them. Maya's expression didn't change. "I made the correct clinical decision in a time-critical situation. Says here you became emotionally involved with the patient's outcome, raised your voice, appeared, quote, agitated during the procedure." Harrington turned his tablet slightly, showing a screen full of incident reports and witness statements. "You need to speak with Dr. Winters about appropriate professional conduct. This isn't the first time your emotional responses have been noted." That's when Dr. Richard Winters appeared from the adjacent office, all 220 pounds of him moving with the authoritative stride of someone who'd spent 30 years in academic medicine before taking this position. He wore his white coat like armor, stethoscope draped precisely around his neck, and carried himself with the kind of confidence that came from never having his judgment seriously questioned. Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. Dr. Chen. His voice carried across the room, causing two residents near the door to kukufro. Straighten instinctively. "We need to discuss your future here." Maya looked at Harrington, then at Winters. "I'm here to discuss my clinical decision-making, which saved the patient's life." "Yes, well, your methods are the issue. Becoming emotionally invested in outcomes leads to rash decisions. Protocol exists for a reason. That's how medicine works." He gestured toward a chair. "Please sit down." Maya stood perfectly still for a moment, calculating. She could explain, could tell him about the split-second assessment, that the standard protocol would have cost precious minutes, could mention the subtle signs she detected that indicated immediate intervention was necessary, could point out that every decision was documented in her notes with clear clinical reasoning. Instead, she simply sat down and placed her hands in her lap. The committee members shifted in their seats, suddenly interested in this small drama unfolding at their table. Even Harrington looked up from his tablet, momentarily engaged by the tension in the room. "Emotional decision-making," Winters announced to the committee, his voice carrying the assurance of someone whose judgment was rarely challenged. "Dr. Chen consistently allows her feelings to override established protocols, shows excessive attachment to patient outcomes. But gut feelings aren't evidence-based medicine." But as Maya sat there, something flickered in her eyes. Not anger, not fear, but something deeper, something that spoke of countless nights spent studying surgical techniques when others were sleeping, of holding dying patients' hands when families couldn't arrive in time, of making split-second decisions where hesitation meant death, where reading subtle cues that others missed had saved countless lives. And in that moment, watching the committee members exchange knowing glances, Maya made a decision that would change everything. She wouldn't argue. She wouldn't get defensive. She would let the system reveal itself, one misjudgment at a time, until the truth had nowhere left to hide. The main ethics committee room was larger than Maya had anticipated, with perhaps 15 seats, around an oval table and a projector screen at the far end where her case files were being displayed for all to evaluate. Dr. Winters sat at the head of the table, flanked by department heads and senior physicians who would determine whether her actions constituted a breach of protocol serious enough to warrant disciplinary action. Winters was in his early 60s, silver-haired and carrying the slight paunch of someone who spent more time in meetings than on his feet, with the kind of institutional authority that came from publishing hundreds of papers while others did the actual clinical work he analyzed. Maya sat alone on one side of the table, her case notes open on her tablet, while the scattered collection of committee members, department representatives, and a few observers filled the remaining seats. In the back corner, two surgical residents, Dr. Priya Sharma and Dr. James Wilson, were observing the proceedings, their conversation a barely audible murmur as they reviewed her case. Maya Chen, case review regarding trauma incident 447B, Dr. Winters announced, looking up from his tablet. Violation of trauma protocol, 23. 5 regarding intervention sequence and direct contradiction of attending physician's orders during multi-vehicle trauma case. Recommendation for supervised cases, pending review. Maya straightened slightly, her posture unconsciously shifting as she prepared to defend herself. The movement was subtle, but it carried the kind of focus that came from years of standing in operating rooms, where precision meant survival. Your clinical notes indicate you administered TXA and performed a REBOA before completing the primary survey. Winters continued, his voice carrying the impatience of someone who'd already reached his conclusion. That's not just out of sequence. It's reckless. The patient presented with signs of internal hemorrhage that weren't immediately obvious to the trauma team, Maya replied, her voice steady. Waiting would have cost minutes we didn't have. That's not your call to make. When an attending is present, Winters interrupted. Trauma protocols exist for a reason. Your job is to follow them, not interpret them based on hunches. Behind them, Sharma leaned over to Wilson. Another one of her intuition cases, she whispered. She always thinks she sees something nobody else does. Wilson nodded, not looking up from the case file. Always the same story. I just knew. I could tell. I sensed something was wrong, getting tired of the drama. Their voices were just loud enough to carry to the front of the room. Maya's jaw tightened almost imperceptibly, but she kept her eyes forward, her breathing controlled. She'd heard worse in surgical suites where being a woman of color meant constantly having to prove yourself. This was just another kind of battlefield. Given your history of emotional decision-making and this latest protocol violation, Dr. Winters continued, I'm recommending continued supervision and reassignment from the trauma response team until further notice. He tapped his tablet once, that decisive gesture serving as his version of a gavel strike. Any objections from the committee? Maya was about to respond when something happened that nobody expected. As she reached for her tablet to pull up additional case notes, her white coat sleeve rode up slightly, revealing her wristwatch. Not just any watch, but a simple analog Seiko with a worn leather band. Most wouldn't have noticed anything special about it, but Dr. Harold Kim, the elderly nephrology consultant sitting near the end of the table, suddenly froze, staring at the timepiece. That watch, he said, his voice cutting through the procedural monotony. Where did you get that watch, Dr. Chen? The question seemed so out of place that several committee members looked up in confusion. Maya glanced down at her wrist. It was a gift from a patient's family in Chicago. Dr. Kim set down his pen, his file forgotten on the table. He'd spent 45 years in medicine before semi-retirement, and he'd seen thousands of physician-patient interactions, but something about that watch had captured his complete attention. A Seiko 5 SNK 809, he said, his voice gaining certainty. Automatic movement, military style. Not expensive, but incredibly reliable. Maya looked surprised. Yes, that's right. The Vasquez case, Kim said slowly. Chicago Presbyterian, 2018. The teenage boy with the ruptured aneurysm that nobody caught. The room fell silent as everyone turned to look at Kim, then back to Maya. How did you know that? Maya asked quietly. Kim straightened in his chair, suddenly animated. I was consulting at Chicago Presbyterian that month. That case was legendary. 14-year-old came in with what everyone thought was a migraine. 3 different doctors saw him. Everyone followed protocol perfectly. Maya's expression remained neutral, but her right hand unconsciously moved to touch the watch face. The father was a watchmaker, Kim continued, his voice gaining strength as the memory clarified. Mexican immigrant who saved for years to open his own shop. The boy was his only child. The committee room was completely still now, the routine review temporarily forgotten as Kim continued. They were about to discharge him with migraine medication when a young surgical resident insisted. Something was wrong. Fought with the attending. Demanded a CT scan that wasn't indicated by protocol. Made such a scene they nearly called security. Dr. Winters shifted uncomfortably. Dr. Kim, this is interesting but not relevant to our current. The CT showed a massive cerebral aneurysm on the verge of rupture, Kim continued, ignoring Winters. It ruptured during emergency surgery. The resident stayed in that OR for 22 hours straight. Refused to leave even when the neurosurgeon offered to take over. All eyes in the room turned to Maya, who sat perfectly still, her expression carefully controlled. The boy survived, Kim said, his voice softening. Against all odds, with no neurological deficits. The father gave his most prized watch to that resident. Said it was nothing compared to what she'd given him, but it would remind her that sometimes time is the most precious thing we have. The weight of that revelation settled over the small group like a heavy blanket. Maya Chen, the doctor they'd then dismissing as emotionally unstable, as too passionate, as unable to follow protocol, had saved a boy's life by trusting her instincts over established procedures. That was you, Kim said, not as a question but as a statement of fact. You were that resident. Maya didn't answer immediately, but the subtle shift in her posture confirmed what Kim already knew. Dr. Chen, Winters began, his voice carrying a note of uncertainty that hadn't been there before. This is an interesting anecdote, but it doesn't change the fact that protocols exist for a reason. One successful deviation doesn't justify. It wasn't just one, Kim interrupted, his eyes never leaving Maya's face. After the Vasquez case, I looked into her record. There were others. A pulmonary embolism diagnosed when all signs pointed to pneumonia. A vertebral artery dissection caught when everyone else saw migraine. A subtle sepsis presentation identified hours before the patient crashed. Kim turned to face Winters directly. Each time she went against protocol. Each time she faced criticism for being too emotional, too invested. And each time she was right. The conference room had grown completely silent. Even the residents in the back had stopped their whispering, staring at Maya with new interest. So when you say she's too emotional, Kim continued, addressing Winters but looking around the room, what you're really saying is that she cares enough to look beyond the algorithm, to see the patient, not just the protocol. Dr. Winters cleared, his throat visibly uncomfortable with this unexpected turn. Dr. Kim, with all due respect, your anecdotes from another hospital several years ago don't change the fact that Dr. Chen directly contradicted her attending's orders in a level 1 trauma situation. And was she right? Kim asked simply. The question hung in the air like a challenge. Winters shuffled through the files on his tablet, but the answer was already there in the patient outcome report. The patient survived, he admitted reluctantly. But that's not the point. That is precisely the point, Kim countered. Medicine isn't just about following protocols. It's about knowing when the protocol doesn't fit the patient in front of you. Maya sat quietly through this exchange, her expression unchanged. She'd learned long ago that the most powerful position in any confrontation was calm certainty. The kind of certainty that came from knowing you were right, even when everyone around you questioned your judgment, Dr. Harrington, who had been silent until now, finally spoke. The trauma report indicates that Dr. Chen identified signs of internal bleeding that weren't obvious on initial assessment. Her notes document specific visual cues that informed her decision. He looked up from his tablet. The question isn't whether she was right clearly. The outcome suggests she was. The question is whether we're creating an environment where physicians feel they can't trust their clinical judgment if it conflicts with protocol. The room fell silent as committee members considered this perspective. Winters looked increasingly uncomfortable, caught between defending the system and acknowledging that the system might have failed in this instance. Dr. Chen, Kim said gently, would you tell us what you saw in that trauma bay that made you override protocol? Maya took a deep breath. This was the moment to either retreat into professional jargon or to speak the truth that had guided her. Throughout her career, she chose the latter. The patient's left earlobe was pale, she said simply. Not blue, not dusky, just slightly paler than the right. Most people wouldn't notice, but it's a subtle sign of internal hemorrhage I've seen. Before, his blink rate was irregular, another subtle autonomic response to blood loss. And there was a slight delay in capillary refill that wasn't dramatic enough to flag on the primary survey, but it was there if you knew to look. She paused, looking around the room. None of these signs would trigger protocol intervention. None would show up on the standard assessment. But together, they told me this patient was actively bleeding internally and didn't have time for us to complete the standard sequence. The clinical precision of her explanation silenced even her critics. This wasn't emotion overriding reason. This was a level of observational skill that transcended standard assessment. Dr. Kim nodded slowly. That's not emotional decision-making. That's exceptional clinical acumen. Winters shifted in his seat, clearly reassessing the situation. Dr. Chen, why didn't you explain these observations to the attending at the time? I tried, she replied simply. I was told, and I quote, we follow protocol here, not hunches. There wasn't time to debate. The patient needed immediate intervention. The implications of that statement rippled through the room. This wasn't a case of an emotional doctor ignoring protocol. This was a physician whose advanced observational skills had been dismissed as feminine intuition, whose intensity had been labeled as emotional instability. Dr. Harrington closed his tablet with a decisive gesture. I think we need to reconsider the framing of this review. Maya remained perfectly composed, but for the first time since the meeting began, there was a subtle shift in the energy around her. The committee members were looking at her differently, now not as a problem to be managed, but as a physician whose skills might exceed the boundaries of standard assessment. And sitting there in the conference room, listening to the conversation shift around her, Maya allowed herself a moment of vindication. She'd spent years having her intensity mistaken for emotionality, her precision for anxiety, her commitment for instability. But the truth was finally emerging, one revelation at a time, that what they had labeled as emotional might actually be exceptional. Dr. Sanvi Mehta, the chief of emergency medicine, had been silently observing from the corner of the room. At 58, she carried the quiet authority of someone who had fought similar battles throughout her own career. Now she leaned forward, her voice cutting through the murmurs that had broken out around the table. I'd like to review the trauma bay footage, she said. Winters looked startled. The video record? That's not standard procedure for this type of review. Neither is dismissing a physician's clinical observations as emotional, Mehta replied coolly. If Dr. Chen documented specific physical signs that informed her decision, those should be visible in the trauma bay recording. The implication was clear. This would either validate Maya's claims or expose them as post hoc justification. It was a gamble, but Mehta's expression suggested she already knew what they would find. 20 minutes later, the committee sat in stunned silence as they replayed the trauma bay footage for the third time. There it was, exactly as Maya had. Described the asymmetric color in the earlobes, the irregular blink pattern, the subtle delay in capillary refill that most would have missed. And more damning, the clear moment when Maya had attempted to point these out to the attending physician, only to be waved off with barely concealed irritation. "Play it again," Winters said quietly, his earlier certainty replaced by something that looked like growing discomfort. They watched as Maya made the decision to act against orders, moving with swift precision to administer the treatment that ultimately saved the patient's life. There was no hesitation, no emotional outburst, just the calm, focused actions of a physician who knew exactly what she was seeing and what needed to be done. When the video ended, Dr. Mehta broke the silence. "That's not emotional decision-making," she said firmly. "That's what excellence looks like." The room remained quiet as committee members processed what they had witnessed. Winters looked as though he'd been confronted with evidence that challenged beliefs he'd held throughout his career. "Dr. Chen," he finally said, his voice lacking its earlier confidence, "it appears we may have mischaracterized your clinical approach." Maya nodded slightly, accepting this awkward approximation of an apology without comment. "I would like to review your previous cases," Dr. Kim said, addressing both Maya and the committee. "I suspect we'll find similar examples of exceptional observation being mislabeled as emotional intensity." "Agreed," Mehta added. "And I'd like to understand why these observations were consistently dismissed by supervising physicians. This raises concerning questions about our clinical culture." Winters cleared his throat uncomfortably. "Let's not get ahead of ourselves. One case doesn't." "It's not one case," Kim interrupted firmly. "I've already mentioned the Chicago incidents. And I'm willing to bet there are others right here that we've misinterpreted." The implication hung in the air, uncomfortable but impossible to ignore. How many times had Maya's insights been dismissed not because they were wrong, but because they came from a woman who showed her commitment too openly? How many times had intensity been mislabeled as emotion, passion as instability? Dr. Priya Sharma, the resident who had earlier dismissed Maya's methods, raised her hand tentatively. "I'd like to speak if I may." Winters nodded, perhaps grateful for the interruption. 3 months ago, Sharma began, her voice gaining confidence as she spoke, Dr. Chen questioned my assessment of a patient with atypical chest pain. Everyone else had signed off on anxiety disorder, but she insisted something was wrong. Made me run additional tests that weren't indicated by protocol. Sharma paused, looking directly at Maya. I thought she was being dramatic, honestly, overreacting. But the test showed a small pulmonary embolism that would have been missed. The patient would have been discharged. The young resident's admission added another layer to the emerging picture. This wasn't just about Maya's skills, but about a pattern of dismissal that had potentially serious consequences for patient care. How many cases have we missed? Mehta asked quietly, the question directed at everyone and no one. How many subtle presentations have we overlooked because we valued protocol adherence over observational acuity? The question lingered, uncomfortable and challenging. Maya remained silent, letting the implications sink in around the table. Finally, Harrington spoke. I believe this review needs to be completely restructured. Rather than questioning Dr. Chen's judgment, perhaps we should be examining how her observational skills could inform our training programs. Maya's expression didn't change, but for those watching closely, there was a subtle release of tension in her shoulders, the first indication that the tide was turning. Dr. Wilson, the other observing resident who had earlier dismissed Maya's methods, looked thoughtful. Dr. Chen, how did you learn to notice these subtle signs? They're not in any of our textbooks. It was the first question that treated her as an expert rather than a problem, and Maya considered it carefully before responding. Pattern recognition developed over time, she explained. I started keeping detailed notes of subtle presentations that preceded major events. Eventually, I began to see connections, small signs that consistently appeared before specific conditions manifested. None of them definitive on their own, but together, they create a picture that can't be ignored. Her explanation was precise, methodical, the opposite of the emotional reactivity she'd been accused of. That's not something that can be protocolized, Winters admitted reluctantly. It's a kind of clinical mastery that comes from exceptional observation and experience. No, Maya agreed quietly. But it is something that can be taught, if we value it instead of dismissing it. The implications of that statement settled over the committee like a challenge. What they had been interpreting as emotional intensity was actually a form of medical brilliance, one that their system was structured to suppress rather than nurture. Dr. Mehta straightened in her chair, a decision visibly forming. I'd like to propose that we not only dismiss this review, but establish a working group to examine how Dr. Chen's observational methodologies could be incorporated into our training program. Winters looked like he wanted to object but found no grounds to do so. The evidence was too clear, the implications too significant to dismiss. And, Mehta continued, I believe we should reconsider Dr. Chen for the trauma department leadership position. Someone with her observational skills is precisely what our program needs. The suggestion sent a ripple of murmurs around the table. Just 30 minutes earlier, Maya had been fighting to defend her basic clinical judgment. Now she was being considered for a leadership role that had previously been denied her. Maya herself remained composed, but there was a new steadiness in her posture, not the rigid tension of someone under attack, but the quiet confidence of a physician whose skills had finally been recognized. As the meeting concluded and people began gathering their materials, Dr. Kim approached Maya quietly. The watch, he said, nodding toward her wrist. You wear it every day? Maya nodded, her right hand unconsciously moving to touch the worn leather band. It reminds me why I do this. Why it matters to see what others miss. Kim smiled slightly. I've been in medicine for 45 years, Dr. Chen. What you have that level of observational acuity, it's rare. And it's often misunderstood. Especially in women. They called me obsessive in my day. You they call emotional. Same skill, different labels. Maya allowed herself a small smile, the first genuine expression she'd shown throughout the entire proceedings. Thank you for speaking up, she said simply. I should have done it sooner, Kim replied. We all should have. As Maya walked out of the conference room, she felt dozens of eyes following her, some curious, some reevaluating, some slightly ashamed. The narrative that had defined her professional identity for years, too emotional, too intense, too invested, had begun to crumble, revealing something else entirely underneath. Not an emotional liability, but a physician whose exceptional skills had been mislabeled because they didn't fit neatly into established protocols. Not a doctor who cared too much, but one who saw too clearly for a system designed around standardization. The rain had stopped by the time Maya stepped outside the administration wing, the late afternoon sun breaking through clouds to cast long shadows across the hospital grounds. She checked her watch, the Seiko that had unexpectedly changed the course of her career, and calculated that she had just enough time to review her patients' charts before evening rounds. She was already mentally shifting back to clinical work, the meeting's drama receding as she focused on what mattered most, the patients waiting for her care. Because despite everything, the mischaracterization, the dismissal, the constant need to prove herself that had never changed, she'd always known exactly who she was and what she was capable of seeing. Now finally, others were beginning to see it too. The autumn rain pelted against the windows of Pacific Northwest Medical Center like tiny fists demanding entry, the rhythmic drumming almost drowning out the controlled chaos of the emergency department. Dr. Maya Chen stood in the staff lounge, clutching a steaming cup of coffee that had long gone cold, watching raindrops race down the glass while the hospital's fluorescent lights cast everything in that clinical blue-white glow that made even the healthiest people look ill. At 36, she had the kind of quiet resilience that came from years of fighting to be heard in rooms where everyone else seemed to have a louder voice. Her black hair was pulled back in a practical bun, dark eyes that missed nothing behind simple wire-framed glasses, and a perpetual slight furrow between her brows. That spoke of someone who thought deeply before speaking. She wore standard-issue surgical scrubs beneath her white coat, the name tag identifying her as Maya Chen, MD, trauma surgery, slightly askew from her last emergency procedure. To anyone passing by, she looked like just another overworked surgeon taking a rare moment of respite between cases. Maybe contemplating test results. Maybe mentally rehearsing a difficult procedure. Maybe nothing more complicated than trying to remember the last time she'd slept more than 4 consecutive hours. But Maya wasn't here by choice. She was here because the hospital ethics committee had called an emergency meeting to discuss her emotional decision-making during last week's multi-car accident, which had triggered a formal review of her surgical privileges, which had led to a temporary reassignment to supervised cases only, which had somehow resulted in her being passed over for the trauma department leadership position she'd been working toward for 5 years. The kind of professional cascade that could derail a career if you weren't careful. This was her 4th encounter with hospital administration in the past 3 months. First, the chief of surgery had pulled her aside after she'd shed tears while informing a family of their child's death. Then the HR director who'd mentioned concerns about emotional stability in high-pressure situations after she'd raised her voice during a particularly chaotic trauma case. Then the peer review board where a colleague had described her as passionate to a fault, the kind of backhanded compliment that somehow became a permanent part of your professional reputation. Each meeting had generated more scrutiny, more observations, more opportunities for others to interpret her intensity as instability. She'd driven through pouring rain from her apartment downtown, a modest 1-bedroom where she'd crashed for barely 4 hours, after a 36-hour shift before being summoned back to the hospital. It wasn't much, but it was close to work, and proximity had become the most valuable thing in her life. The hospital administration wing occupied the entire 5th floor, its gray carpeting and beige walls creating an atmosphere of deliberate neutrality. The morning air carried the sharp antiseptic smell that permeated every hospital, mixed with coffee from the nearby nurses' station and that particular set of administrative spaces, printer toner, air freshener, and the lingering tension of countless difficult conversations. Maya stepped into the ethics committee meeting deliberately, her movements calculated. She had that economy of motion that comes from years in the OR, where every gesture must be precise, every action purposeful. She checked her phone once, slipped it into her white coat pocket, and pulled a tablet from her bag. The tablet contained her surgical logs and case notes, documenting decisions that should have been straightforward to defend, but had somehow become a professional minefield. The committee room smelled like sanitizer and stale coffee, despite the air purifiers humming quietly in each corner. Fluorescent lights buzzed overhead, casting everyone in that institutional bluish glow that made senior physicians look ancient and junior ones look terrified. Behind the conference table, Dr. William Harrington, head of the ethics committee, was reviewing her case file while simultaneously fielding texts from attending physicians who clearly didn't understand that he couldn't solve their scheduling problems during a formal review. Dr. Chen, Harrington looked up as Maya approached, his expression already sliding into that professional distance administrators perfected after their first decade. Maya placed her tablet on the table, noting how Harrington's eyes briefly took in her appearance. The slight dishevelment of someone who'd been called in during her first real break in days. The lack of makeup, the general air of someone who prioritized patient care over politics. "I'm here for the ethics review. Trauma case from last Tuesday. Multiple vehicle accident." Harrington's fingers moved across his tablet with practiced efficiency, pulling up files while keeping half his attention on Maya and half on the messages that kept appearing on his screen. Dr. Chen. It says here you countermanded attending. Physician orders. Administered treatment against departmental protocol. The trauma director has serious concerns. The words hung in the air between them. Maya's expression didn't change. I made the correct clinical decision in a time-critical situation. Says here you became emotionally involved with the patient's outcome, raised your voice. Appeared, quote, agitated during the procedure. Harrington turned his tablet slightly, showing a screen full of incident reports and witness statements. You need to speak with Dr. Winters about appropriate professional conduct. This isn't the first time your emotional responses have been noted. That's when Dr. Richard Winters appeared from the adjacent office, all 220 pounds of him moving with the authoritative stride of someone who'd spent 30 years in academic medicine before taking this position. He wore his white coat like armor, stethoscope draped precisely around his neck, and carried himself with the kind of confidence that came from never having his judgment seriously questioned. Dr. Chen. His voice carried across the room, causing two residents near the door to straighten instinctively. We need to discuss your future here. Maya looked at Harrington, then at Winters. I'm here to discuss my clinical decision-making, which saved the patient's life. Yes, well, your methods are the issue. Becoming emotionally invested in outcomes leads to rash decisions. Protocol exists for a reason. That's how medicine works. He gestured toward a chair. Please sit down. Maya stood perfectly still for a moment, calculating. She could explain, could tell him about the split-second assessment, that the standard protocol would have cost precious minutes, could mention the subtle signs she detected that indicated immediate intervention was necessary, could point out that every decision was documented in her notes with clear clinical reasoning. Instead, she simply sat down and placed her hands in her lap. The committee members shifted in their seats, suddenly interested in the small drama unfolding at their table. Even Harrington looked up from his tablet, momentarily engaged by the tension in the room. Emotional decision-making, Winters announced to the committee, his voice carrying the assurance of someone whose judgment was rarely challenged. Dr. Chen consistently allows her feelings to override established protocols, shows excessive attachment to patient outcomes. But gut feelings aren't evidence-based medicine. But as Maya sat there, something flickered in her eyes. Not anger, not fear, but something deeper, something that spoke of countless nights spent studying surgical techniques when others were sleeping, of holding dying patients' hands when families couldn't arrive in time, of making split-second decisions where hesitation meant death, where reading subtle cues that others missed had saved countless lives. And in that moment, watching the committee members exchange knowing glances, Maya made a decision that would change everything. She wouldn't argue. She wouldn't get defensive. She would let the system reveal itself, one misjudgment at a time, until the truth had nowhere left to hide. The main ethics committee room was larger than Maya had anticipated, with perhaps 15 seats, around an oval table and a projector screen at the far end where her case files were being displayed for all to evaluate. Dr. Winters sat at the head of the table, flanked by department heads and senior physicians who would determine whether her actions constituted a breach of protocol serious enough to warrant disciplinary action. Winters was in his early 60s, silver-haired and carrying the slight paunch of someone who spent more time in meetings than on his feet, with the kind of institutional authority that came from publishing hundreds of papers, while others did the actual clinical work he analyzed. Maya sat alone on one side of the table, her case notes open on her tablet, while the scattered collection of committee members, department representatives, and a few observers filled the remaining seats. In the back corner, two surgical residents, Dr. Priya Sharma and Dr. James Wilson, were observing the proceedings, their conversation a barely audible murmur as they reviewed her case. Maya Chen, case review regarding trauma incident 447B. Dr. Winters announced, looking up from his tablet. Violation of trauma protocol 23.5 regarding intervention sequence and direct contradiction of attending physician's orders during multi-vehicle trauma case. Recommendation for supervised cases pending review. Maya straightened slightly, her posture unconsciously shifting as she prepared to defend herself. The movement was subtle, but it carried the kind of focus that came from years of standing in operating rooms where precision meant survival. Your clinical notes indicate you administered TXA and performed a REBOA before completing the primary survey. Winters continued, his voice carrying the impatience of someone who'd already reached his conclusion. That's not just out of sequence. It's reckless. The patient presented with signs of internal hemorrhage that weren't immediately obvious to the trauma team, Maya replied, her voice steady. Waiting would have cost minutes we didn't have. That's not your call to make. When an attending is present, Winters interrupted. Trauma protocols exist for a reason. Your job is to follow them, not interpret them based on hunches. Behind them, Sharma leaned over to Wilson. Another one of her intuition cases, she whispered. She always thinks she sees something nobody else does. Wilson nodded, not looking up from the case file. Always the same story. I just knew. I could tell. I sensed something was wrong, getting tired of the drama. Their voices were just loud enough to carry to the front of the room. Maya's jaw tightened almost imperceptibly, but she kept her eyes forward, her breathing controlled. She'd heard worse in surgical suites where being a woman of color meant constantly having to prove yourself. This was just another kind of battlefield. Given your history of emotional decision-making and this latest protocol violation, Dr. Winters continued, I'm recommending continued supervision and reassignment from the trauma response team until further notice. He tapped his tablet once, that decisive gesture serving as his version of a gavel strike. Any objections from the committee? Maya was about to respond when something happened that nobody expected. As she reached for her tablet to pull up additional case notes, her white coat sleeve rode up slightly, revealing her wristwatch. Not just any watch, but a simple analog Seiko with a worn leather band. Most wouldn't have noticed anything special about it, but Dr. Harold Kim, the elderly nephrology consultant sitting near the end of the table, suddenly froze, staring at the timepiece. That watch, he said, his voice cutting through the procedural monotony. Where did you get that watch, Dr. Chen? The question seemed so out of place that several committee members looked up in confusion. Maya glanced down at her wrist. It was a gift from a patient's family in Chicago. Dr. Kim set down his pen, his file forgotten on the table. He'd spent 45 years in medicine before semi-retirement, and he'd seen thousands of physician-patient interactions. But something about that watch had captured his complete attention. A Seiko 5 SNK809, he said, his voice gaining certainty. 2 weeks after the ethics committee meeting, Maya found herself standing in the trauma bay during what the staff had begun calling the witching hour. That 2 a.m. period when the hospital seemed to hold its breath between emergencies. The overhead lights hummed with fluorescent constancy, casting everything in that stark clinical brightness that made the stainless steel surfaces gleam like polished mirrors. The change in how people treated her was subtle but unmistakable. Residents who had once whispered behind her back now watched her assessments with careful attention. Attending physicians who had dismissed her concerns now paused to listen when she spoke. Even the nurses who had always respected her clinical skills seemed to view her through a different lens, not as an anomaly in the system, but as someone whose unique abilities might represent something valuable. Dr. Chen? A voice interrupted her thoughts. Maya turned to find Dr. Sharma, the resident who had spoken up during the ethics committee meeting, standing in the doorway, clutching a tablet and looking uncertain. I have a patient in bed 3. 37-year-old male with chest pain. All standard assessments are negative. ECG normal. Initial troponin negative. Vital stable. But something feels off. The hesitation in Sharma's voice was evident. She was caught between her training, which told her to trust the objective measures, and her developing instinct, which was telling her something else entirely. What? Feels off? Maya asked, her tone neutral. That's just it. I can't pinpoint it. He doesn't fit any of the protocols for urgent intervention, but… Sharma trailed off, clearly struggling to articulate her concern. In that moment, Maya recognized something of herself in the younger doctor, the frustration of sensing something important that defied standard classification. Rather than immediately heading to see the patient, she gestured to a nearby stool. Tell me what you're observing, not what the tests are showing. Sharma looked surprised but sat down. His breathing is too regular. Too regular? Maya raised an eyebrow. Yes, it's like he's consciously controlling it. And he keeps touching his left shoulder. But when I asked about pain there, he denied it. His wife mentioned he was unusually tired after climbing one flight of stairs yesterday, but he attributed it to working long hours. Maya nodded slowly, recognizing the value of these observations that wouldn't trigger any protocol alerts but collectively painted a concerning picture. What else? His color is good, but… Sharma paused, then continued with more confidence. His earlobes are slightly pale compared to his face. Maya felt a surge of pride at this observation. The resident had been paying attention. During the ethics committee review, "Let's go see him," Maya said simply. The patient, Mr. Daniels, was sitting up in bed, looking more annoyed than ill. His wife sat beside him, her face lined with worry that contrasted with her husband's apparent calm. "Mr. Daniels, I'm Dr. Chen. Do you mind if I take another look at you?" "Look, I've already told 3 different people. I'm fine. It's probably just heartburn. My wife is overreacting." Maya nodded understandingly as she began her assessment, noting exactly what Sharma had described: the overly controlled breathing, the unconscious touching of his left shoulder, the subtle pallor of his earlobes that contrasted with his otherwise healthy appearance. "Tell me about yesterday. Your wife mentioned you were tired after climbing stairs?" "I've been working 14-hour days. Anyone would be tired," he replied dismissively. Maya noticed something else when he spoke about work. His right index finger tapped against his thumb, a subtle stress response. "I'd like to run one more test, a CT angiogram," Maya said. Mr. Daniels sighed in exasperation. "Is that really necessary?" All the other tests were normal. "I believe it is," Maya replied calmly. "Based on what?" He challenged. "My numbers are fine. The EKG is normal. The other doctor said my blood test was normal." Maya considered her response carefully. In the past, she might have simply ordered the test without explanation, knowing she was right, but unable to articulate why in terms the patient would understand. That approach had often been labeled as poor communication skills in her evaluations, another coded criticism that masked the real issue. She saw patterns others missed and struggled to translate them into standard medical language. "Mr. Daniels, medicine isn't just about numbers and standard tests. It's about patterns. Right now, I'm seeing a pattern that concerns me, subtle signs that together suggest we should look more closely at your heart. I could be wrong, but if I'm right, catching this now could prevent something serious." Her candor seemed to surprise him, and after a moment, he nodded. "Fine, one more test." 40 minutes later, Maya stood with Sharma looking at the CT results, which confirmed her suspicion. A small dissection in the left coronary artery, a tear in the blood vessel wall that could have led to a major heart attack if left untreated. It wasn't large enough to have triggered standard protocols, but it was definitively there. "I would have missed this," Sharma said quietly. "If I had followed protocol alone, I would have discharged him with antacids. But you didn't," Maya pointed out. You noticed something was wrong, even if you couldn't immediately identify what. That's the skill you need to develop, trusting that observation. How do you do it consistently? Sharma asked. How do you see these things when nobody else does? Maya considered the question thoughtfully. I don't think I see things others can't see. I think I've just learned to pay attention to what most people are trained to filter out. Medicine teaches us to look for the obvious signs, the major symptoms, the significant abnormalities. But sometimes the most important clues are subtle. As Maya supervised Mr. Daniel's transfer to the cardiac unit, where he would undergo a procedure to repair the dissection, she reflected on how this case exemplified the very issue at the heart of her recent professional challenges. Her ability to detect these subtle patterns had repeatedly been dismissed as emotional or intuitive, terms that in the male-dominated world of medicine carried connotations of unreliability and lack of scientific rigor. Yet this same ability had just saved a man from a potentially fatal heart attack that standard protocols would have missed entirely. Later that morning, Maya was surprised to receive a message from Dr. Winters asking her to meet him in his office. Despite the vindication of the Ethics Committee review, she remained wary of the man who had so consistently mischaracterized her clinical approach. Winters' office was exactly what one would expect from a hospital administrator who had transitioned from clinical practice to management, walls lined with degrees and certificates, shelves filled with medical texts that probably hadn't been opened in years, and a large desk positioned to emphasize the authority of whoever sat behind it. Dr. Chen, thank you for coming, Winters said, gesturing to a chair. His tone lacked the dismissive edge she had grown accustomed to, replaced by something that sounded almost like respect. I understand you diagnosed a coronary dissection in the ED this morning that standard protocols would have missed. Maya nodded, wondering where this was leading. That's the third critical diagnosis you've made this month that fell outside standard assessment criteria. Winters continued, consulting a file on his desk. The pulmonary embolism in the college student. The early sepsis in the immunocompromised patient, and now this. Maya remained silent, waiting for him to reach his point. The hospital board has asked me to revisit your candidacy for the trauma leadership position, Winters said finally. In light of recent events, they believe, and I concur, that your observational skills represent a valuable asset to the department. The statement hung in the air between them, not quite an apology, but a significant shift from their previous interactions. I appreciate that, Dr. Winters, Maya replied carefully. But I'm curious what changed. My clinical approach is the same as it's always been. Winters looked uncomfortable, adjusting his tie slightly before responding. The board reviewed your case history over the past 3 years. Your diagnostic accuracy in complex presentations is 94%, the highest in the department. Your mortality rates in critical trauma cases are 22% below the hospital average. These are numbers that can't be ignored, regardless of method. Maya noted what remained unspoken, that Winters and others had been willing to ignore these statistics before, because her approach didn't conform to their expectations of how a surgeon should behave or make decisions. And yet they were ignored, she pointed out quietly. For years, my assessments were dismissed as emotional reactions, despite consistently positive outcomes. Winters had the grace to look slightly ashamed. Medicine is traditionally evidence-based. Dr. Chen, your approach seemed unquantifiable. The evidence was always there in the outcomes, Maya replied. But because I couldn't always articulate exactly what I was seeing in terms of established criteria, my observations were categorized as intuition rather than clinical acumen. She leaned forward slightly. And we both know that intuition, when applied to female physicians, carries very different connotations than when applied to male physicians. For men, it's experience. For women, it's emotion. The directness of her statement clearly made Winters uncomfortable, but he didn't deny it. The trauma leadership position, he said, steering the conversation back to safer ground. Are you interested? Maya considered the offer. Just 3 weeks ago, this position had been denied her explicitly because of concerns about her emotional decision-making. Now it was being offered as a recognition of the very same qualities, simply relabeled as exceptional observational skills. I'm interested, she said finally, but I have conditions. Winters looked surprised. He clearly hadn't expected negotiation. What conditions? First, I want to develop a training program for residents focused on observational diagnostics, teaching them to recognize subtle clinical patterns that don't fit standard protocols. Winters nodded slowly. That seems reasonable. Second, I want a formal review of how we evaluate clinical decision-making, particularly for physicians whose approaches don't fit conventional models. We're missing valuable perspectives by dismissing what we can't immediately quantify. This request clearly made Winters more uncomfortable, but after a moment, he nodded again. And third, Maya continued, I want a formal acknowledgement from the department that my previous evaluations contained gender-biased language and assessments. Not as punishment, but as recognition that we need to do better. Winters stiffened. Dr. Chen, that's a significant allegation that would require— It's not an allegation. It's a documented fact, Maya interrupted calmly. My file contains 17 instances where my clinical decisions were described as emotional or intuitive, despite positive outcomes. Male colleagues with similar approaches were described as experienced or decisive. Dr. Kim has already begun compiling the comparative language analysis. The mention of Dr. Kim, whose reputation and seniority carried considerable weight, seemed to give Winters pause. I'll bring your conditions to the board, he said finally. Maya nodded and stood to leave. At the door, she paused. One more thing, Dr. Winters. The reason I could diagnose Mr. Daniels this morning is because Dr. Sharma is learning to trust her own observations rather than just following protocols. That's the kind of physician we should be developing, one who sees the patient, not just the procedure. As Maya walked back to the trauma department, she reflected on how much had changed in just 2 weeks. The system that had consistently devalued her skills was now not only recognizing them, but potentially restructuring itself to accommodate them. It was a significant shift, but she harbored no illusions that institutional change would come easily or quickly. When she reached the trauma bay, she found Dr. Kim waiting for her, a file folder in his hands. I heard about your meeting with Winters, he said without preamble. The language analysis you mentioned, I've actually completed it. He handed her the folder. Inside was a meticulous comparison of performance evaluations for male and female physicians in the department, with specific language highlighted and categorized. The pattern was unmistakable and damning. Identical clinical behaviors were consistently described in gendered terms that disadvantaged female physicians. This is comprehensive, Maya said, impressed by the thoroughness of the analysis. I've had concerns about evaluation bias for years, Kim admitted. But it took your case to motivate me to document it properly. The board won't be able to ignore this. Maya studied the older physician thoughtfully. Why did you decide to speak up now, Dr. Kim? You've been at this hospital for years. You must have seen similar situations before. Kim looked slightly ashamed. I have, and I've spoken up occasionally, but never as forcefully as I should have. Perhaps I was too comfortable in the system, even while recognizing its flaws. He paused, then continued with greater conviction. But watching what happened in that ethics committee meeting, seeing a brilliant physician nearly sidelined because her excellence didn't fit our preconceptions, it was too blatant to ignore. Sometimes it takes a particularly clear example to make us confront what we've been tacitly accepting. Their conversation was interrupted by the trauma alert system blaring overhead. Multiple casualties inbound from a building collapse downtown. ETA 10 minutes. "We'll continue this later," Maya said, already shifting into trauma response mode, her mind calculating resources, personnel, and priorities. By the time the first ambulances arrived, Maya had transformed the trauma bay into a model of organized efficiency. Residents and nurses moved with purpose, each understanding their role in the complex choreography of multiple trauma response. This was where Maya's true leadership skills became most evident, not in administrative meetings or policy discussions, but in the controlled chaos of life and death decision-making. The first patient arrived with crushing chest injuries and an obviously compromised airway. The paramedics were performing manual ventilation, but Maya immediately observed signs they had missed: the slight asymmetry in chest movement, the faint bluish tinge to the right earlobe, the way the neck veins distended differently on each side. "Tension pneumothorax developing on the right," she announced calmly. "Prepare for immediate decompression." Dr. Wilson, who had once dismissed her methods, moved quickly to prepare the necessary equipment, no longer questioning her assessment. Despite the lack of obvious clinical signs, the trust that had been absent just weeks ago was now immediate and complete. As Maya performed the needle decompression that would prevent imminent cardiovascular collapse, she maintained a steady stream of explanation for the residents observing nearby. "Notice the subtle signs before the obvious ones develop," she instructed. "Uneven chest movement, asymmetric coloration, differential venous distension. By the time the standard signs appear in the textbook progression, you've lost critical minutes." The second and third patients arrived in quick succession, one with head trauma, the other with multiple fractures but stable vitals. Maya assigned teams to each, circulating between them with calm efficiency, making rapid assessments and adjustments that kept all three patients stabilized despite the severity of their injuries. Then the fourth ambulance arrived, and the atmosphere in the trauma bay shifted perceptibly. The paramedic's face was grim as they wheeled in a young woman, perhaps 25, with a metal beam impaled through her abdomen, a catastrophic injury with minimal chance of survival. "Construction site collapse," the paramedic reported tersely. "Beam fell from 3 stories up, impaled on site. BP's dropping, 80/40ths and falling, pulse 140, thready. Type O blood requested en route." Maya moved to the patient immediately. Her assessment swift but thorough. The situation was dire. The beam had almost certainly lacerated major blood vessels and possibly the liver. Standard protocol for such injuries was clear: stabilize the object, get imaging, then move to the operating room for controlled removal. But Maya recognized immediately that this patient wouldn't survive that timeline. "We're removing it here," she announced, causing several heads to turn in surprise. "She'd bleed out before we reach the OR." Dr. Winters, who had come down to observe the multiple casualty response, stepped forward with alarm. "Dr. Chen, protocol for impalement injuries is clear. Removal without imaging and OR preparation will be her only chance of survival," Maya finished firmly. "She has minutes, not the 40 it would take to follow protocol. I need 2 units of ONEG now, vascular clamps and an abdominal tray." There was a moment of tension as Winters seemed poised to countermand her order. Their eyes locked, and in that moment, the entire dynamic of their professional relationship hung in the balance. Would he revert to the old pattern of dismissing her judgment, or would he trust the clinical acumen that had been so recently validated? After what seemed like an eternity but was actually only seconds, Winters stepped back. "Do what you need to do, Dr. Chen." The next 17 minutes were a masterclass in trauma management. Maya orchestrated the careful removal of the beam, while simultaneously controlling the catastrophic bleeding that followed. Her hands moved with surgical precision, clamping torn vessels, identifying critical structures, and stabilizing the patient's condition through a procedure that should never have been performed outside an operating room. Throughout, She maintained a calm running commentary for the benefit of the residents assisting her, explaining each decision, each observation, each technique. This wasn't just trauma care. It was trauma education of the highest order. "Pulse is stabilizing," the nurse reported with barely concealed surprise. "BP coming up, 90/60ths and rising." "Get her to OR2 now," Maya ordered. "Dr. Sharma, you're with me. Dr. Wilson, continue managing patients 1 and 3. Dr. Kim, patient 2 is stable, but watch for signs of increasing intracranial pressure. His right pupil was slightly less reactive on my last check." As the trauma team mobilized to transfer the critically injured woman to surgery, Maya caught Winters watching her with an expression she'd never seen on his face before. Not just respect, but something approaching awe. The surgery that followed lasted 6 hours, with Maya performing vascular repairs that challenged the limits of surgical possibility. Twice the patient nearly slipped away, and twice Maya's extraordinary observational skills allowed her to identify and address problems before they became catastrophic. When she finally stepped back from the operating table, the patient was stable against all odds and all expectations. "She survived," Maya told Sharma as they scrub it out. "The recovery will be long, but she live." "That wasn't in any protocol I've ever studied," Sharma said quietly. "No," Maya agreed, "it wasn't. Sometimes you have to see beyond the protocol to the patient in front of you. That's what I've been trying to teach all along." As they exited the OR, they found Dr. Winters waiting in the hallway. His earlier skepticism had been replaced by a thoughtful expression. "Remarkable work in there, Dr. Chen," he said, with genuine admiration. "You were right about the timeline. She wouldn't have survived the standard approach." Maya nodded, too tired for triumph or vindication. "Thank you for not interfering. I'm beginning to understand what Dr. Kim has been trying to tell me." Winters admitted, "What you have, this ability to see patterns, to notice what others miss, it isn't emotional at all. It's a form of clinical excellence that our systems aren't designed to recognize or nurture." For Maya, this acknowledgement represented something she had sought throughout her career. Not praise or advancement, but simply recognition that her approach to medicine was valid. That seeing deeply, caring intensely, and acting decisively were strengths, not liabilities. "Your conditions for the trauma leadership position," Winters continued. "The board has approved all 3, including the formal acknowledgement of gender, BIAS in evaluations. They've also authorized the creation of an observational diagnostics program under your direction." Maya's exhaustion momentarily gave way to surprise. She hadn't expected such a complete acceptance of her terms, particularly the acknowledgement of bias, which she had anticipated would meet the most resistance. What changed their minds? "The data was compelling," Winters replied. Dr. Kim's analysis left little room for debate, but more than that. They watched the trauma response today. They saw what happens when your skills are embraced rather than questioned. 4 critical patients, 0 fatalities, including one that every protocol would have categorized as unsalvageable. As Maya finally headed to the break room after the longest shift of her career, she found herself thinking not about the professional victory or the institutional changes she had catalyzed, but about the young woman whose life she had saved by trusting her own judgment over established protocol. That was what mattered most, not being proven right, but being effective, not changing minds, but saving lives. The system's recognition was gratifying, but it was secondary to the fundamental purpose that had driven her all along: seeing what needed to be seen, doing what needed to be done, regardless of whether others understood or approved. In the break room, she found Sharma and Wilson waiting, along with several other residents who had witnessed the day's events. There was a palpable sense of excitement among them, a hunger for knowledge that hadn't been there before. "Dr. Chen," Wilson began, his former dismissiveness replaced by genuine respect, We were hoping you might tell us more about your observational techniques. How you spotted the tension pneumothorax before the standard signs appeared. How you knew the impalement patient couldn't wait for the OR. Maya looked at their eager faces and felt something shift within her. For years she had been the outlier, the one whose methods were questioned and whose intensity was criticized. Now suddenly, she was being asked to teach those very same methods to the next generation of physicians. It's not a technique that can be learned overnight, she said honestly. It's about training yourself to see patterns, to notice subtle deviations, to recognize the significance of signs that might seem minor in isolation. Can it be taught? Sharma asked. Maya considered the question carefully. Yes, she said. Finally, it can be taught, but not through traditional methods. Not through textbooks and lectures. It has to be learned through observation, through practice, through developing a different way of seeing. Will you teach us? Wilson asked simply. The question hung in the air, representing not just a request for knowledge but an acknowledgement that what had once been dismissed as emotional intensity was actually a form of medical brilliance, one that could transform how they practiced medicine. Yes, Maya said, feeling the weight of this new responsibility settle alongside her clinical duties. I will teach you. Not just the what, but the why and the how. Not just to follow protocols, but to know when they don't serve the patient in front of you. As the residents gathered around, their faces alight with the excitement of discovering a new dimension to their medical practice, Maya realized that the very qualities that had once made her an outsider were now positioning her as a leader, not despite her so-called emotionality, but because of the extraordinary perceptiveness that others had mislabeled. The system that had tried to contain her was now expanding to accommodate her vision. The approach that had been dismissed as too emotional, too intense, too invested was now being recognized as exactly what medicine needed: the ability to see beyond the obvious, to care enough to look deeper, to have the courage to act on what you observed even when others couldn't yet see it. In that moment, standing before colleagues who now looked to her for guidance rather than questioning her judgment, Maya understood that what had changed wasn't her. It was their perception. And in that shift of perception lay the possibility of transforming not just one department or one hospital, but perhaps the very culture of medicine itself. 6 months later, the auditorium of Pacific Northwest Medical Center was filled to capacity. Physicians, nurses, residents, and medical students from across the region had gathered for the inaugural conference on observational diagnostics, a new approach to medical education that had grown from the seed of Maya's experiences. On stage, beneath the spotlights that made her white coat almost luminous, Dr. Maya Chen stood before the assembled crowd with a calm confidence that seemed to radiate outward. No longer the outsider fighting to be heard, she had become the center of a movement that was quietly transforming medical practice beyond the walls of her own hospital. Medicine has always existed at the intersection of science and art. She began, her voice carrying clearly through the auditorium. We pride ourselves on evidence-based protocols, standardized assessments, and quantifiable metrics. These are the foundations of good care, and they should be. But today, I want to talk about what happens in the spaces between protocols, in the subtle patterns that don't fit neatly into our checklists and algorithms. The audience listened with rapt attention as Maya shared case studies from the observational diagnostics program she had developed over the past 6 months. On screens behind her, images illustrated the subtle clinical signs that traditional training often missed: the asymmetric coloration, the micro-expressions of pain, the barely perceptible changes in respiration that could signal impending crisis before standard vitals showed any abnormality. What we've found, she continued, is that these observational skills can be taught, developed, and refined. They aren't magical intuition or emotional reactions. They're a sophisticated form of pattern recognition that complements our established protocols rather than contradicting them. In the front row, Dr. Winters sat watching with an expression of genuine interest. Over the months since the Trauma Bay incident, he had undergone his own transformation, from Maya's most vocal critic to one of her most supportive allies. The formal acknowledgement of gender bias in evaluations that she had demanded had led to a hospital-wide reassessment of performance reviews, revealing patterns of inequality that extended far beyond Maya's individual case. "The challenge we face," Maya continued, "isn't choosing between protocols and observation, between standardized care and individualized assessment. It's integrating them into a more comprehensive approach to medicine, one that values both the science of measurement and the art of seeing." As she spoke, she noticed a familiar face entering at the back of the auditorium, Dr. Sanvi Mehta, the chief of emergency medicine, who had championed Maya's methods from the moment she reviewed the Trauma Bay footage. Beside her was a woman Maya didn't recognize, tall, silver-haired, with the bearing of someone accustomed to authority. Maya continued her presentation, moving from theory to practical applications. She shared videos of residents trained in her program, identifying subtle signs of deterioration minutes before standard monitors detected any change. She presented outcome data showing improved survival rates, reduced complications, and earlier interventions across multiple departments. "What started as one physician's approach has become something much larger," she said, acknowledging the team that had formed around the program. "Dr. Sharma now leads our resident training. Dr. Wilson has developed a simulation program specifically designed to enhance observational skills. Dr. Kim has created assessment tools that quantify what was once dismissed as unquantifiable." The audience erupted in applause as Maya invited her team to join her on stage. The same residents who had once whispered about her emotional approach now stood as colleagues and collaborators in a program that was gaining national attention. As the formal presentation concluded and attendees broke into workshop sessions, Maya found herself approached by Dr. Mehta and the silver-haired woman she had noticed earlier. "Dr. Chen," Mehta said warmly, "I'd like to introduce Dr. Eleanor Blackwood, Director of the National Institute for Medical Education." Maya felt a moment of genuine surprise as she shook hands with one of the most influential figures in medical education policy. "Dr. Chen," Blackwood said with a crisp British accent, "your work here is causing quite a stir in educational circles. I flew in specifically to see this program firsthand." "It's an honor to meet you," Maya replied, genuinely impressed that her work had drawn such high-level attention. "Dr. Blackwood is considering your program as a model for a national initiative," Mehta explained, unable to contain her excitement. "The Institute is developing new standards for medical education, and your observational diagnostics approach could be incorporated into medical schools across the country." The implications of this were momentous. What had begun as Maya's personal struggle against mischaracterization could potentially reshape how medicine was taught to future generations of physicians. "We'd like to discuss the possibility of you joining our advisory board," Blackwood continued. "Your perspective would be invaluable as we rethink certain aspects of medical training." As they walked toward a quieter area to continue their conversation, Maya caught sight of a young woman sitting in a wheelchair near the edge of the lobby. Something about her seemed familiar, and after a moment, Maya recognized her, the impalement injury patient whose life she had saved 6 months earlier by breaking protocol in the Trauma Bay. "Excuse me for a moment," Maya said to Blackwood and Mehta before crossing to the young woman. "Alicia," she said, genuinely surprised to see her former patient. "I didn't expect to see you here." The young woman looked up with a smile that transformed her face. The last time Maya had seen her, she had been unconscious, fighting for her life. Now, despite the wheelchair, she radiated a vitality that spoke of remarkable recovery. "Dr. Chen," Alicia said, reaching out to grasp Maya's hand. "I've been trying to meet you again since I woke up. They told me what you did, that you broke all the rules to save me when everyone else said it was hopeless. Maya shook her head. Slightly. I didn't break the rules. I just recognized when they needed to be adapted to serve the actual patient in front of me. Whatever you call it, I'm alive because of you, Alicia insisted. And not just alive. I'm starting physical therapy next week. The neurologists say I might even walk again, which they originally said would be impossible. There was something in the young woman's determined expression that resonated with Maya, a refusal to accept limitations imposed by others' expectations. I heard about your conference and had to come, Alicia continued. I'm starting nursing school in January. What happened to me? It changed everything. I want to learn to see people the way you saw me. The full circle moment wasn't lost on Maya. Her fight to be valued for her unique abilities had not only saved this young woman's life, but inspired her to enter healthcare herself, potentially bringing a similar perspective to her own practice. Medicine needs people who can see beyond the obvious, Maya said, squeezing Alicia's hand. Who understand that patients are more than the sum of their test results. As she rejoined Blackwood and Meta, Maya found herself reflecting on the extraordinary journey of the past 6 months. What had begun as a personal vindication had evolved into something far more significant, a movement to transform medical education itself. Later that afternoon, as the conference workshops concluded, Maya found herself in an unexpected meeting. The hospital board had convened with Dr. Winters, Dr. Blackwood, and representatives from 3 other major teaching hospitals in the region. Maya entered the boardroom with curiosity rather than the apprehension such meetings had once provoked. Dr. Chen, the board chairwoman began, we've been discussing the future of the observational diagnostics program in light of the national interest it's generating. Maya waited, sensing there was more to this meeting than simple acknowledgement. We'd like to propose establishing a dedicated center for observational medicine, the chairwoman continued, with you as its founding director. This would expand beyond the current program to include research, education, and clinical application across multiple specialties. The proposal was more ambitious than anything Maya had imagined, not just a training program, but an entire institutional structure dedicated to developing and spreading the approach she had pioneered. The National Institute is prepared to provide significant grant funding, Blackwood added. We see this as a potential model for similar centers across the country. As the details of the proposal unfolded, Maya found herself facing a new kind of challenge, not fighting for recognition, but determining how to scale her vision without losing its essential qualities. How to institutionalize an approach that had begun as a deeply personal response to the limitations of standardized medicine. This is substantial, she said finally, when the presentation concluded. But I have concerns about how we maintain the core principles as we expand. This isn't just about teaching people to look for specific signs. It's about cultivating a fundamentally different way of seeing patients. That's precisely why you need to lead it, Dr. Winters said, with a sincerity that would have been unimaginable 6 months earlier. To ensure it doesn't become just another checklist approach, Maya considered the proposal thoughtfully. I'll need full autonomy over curriculum development. And the center should include nurses, therapists, and other healthcare providers, not just physicians. The observational skills we're developing apply across disciplines. Agreed, the chairwoman said, with a nod to the board members. What else? Integrated research on bias in healthcare, Maya continued, growing more confident as she shaped the vision. Not just gender bias, but all the ways our preconceptions affect how we see and treat patients. If we're teaching people to observe more accurately, we need to acknowledge the filters that distort our observations. The board members exchanged glances, but no one objected. And finally, Maya said, I want to develop a patient partnership program. Patients like Alicia Torres, who've experienced both the failures and successes of our observational abilities. They have insights we need to incorporate. By the end of the meeting, the framework for the Center for Observational Medicine had taken shape, a vision far beyond what Maya could have imagined when she sat in that ethics committee meeting 6 months earlier, defending her clinical decisions against charges of emotional instability. As the meeting concluded and people began to gather their materials, Dr. Blackwood approached Maya privately. "There's something else," she said quietly. "Something not yet formalized but important for you to know. The Institute is considering major revisions to the core competencies for medical education. We're looking at adding observational acuity as a fundamental skill alongside the traditional competencies." The significance of this was enormous. The core competencies shaped medical education across the country, determining what skills and abilities were considered essential for every physician to develop. "If adopted," Blackwood continued, "it would mean that what you've been fighting for wouldn't be considered alternative or supplementary. It would be recognized as a fundamental component of medical practice, taught from the first day of medical school." Maya felt the weight of this potential transformation, not just for her personally, but for the entire field of medicine. What had once been dismissed as her emotional intensity could become part of the foundation of medical education itself. As Maya left the hospital that evening, the sunset painted the western sky in shades of gold and crimson. She paused on the steps, watching hospital staff changing shifts, the rhythmic cycle of healthcare continuing regardless of conferences, proposals, or institutional transformations. A young resident hurried past, then stopped and turned back. "Dr. Chen," she said, slightly breathless, "I just wanted to say I attended your workshop today on recognizing early sepsis indicators. I went straight back to the ward and checked on a patient who'd been concerning me, even though his numbers looked okay. You were right about the earlobe coloration and the subtle changes in mental status. We started antibiotics 2 hours earlier than we would have otherwise." The simplicity of this statement, one patient, seeing more clearly, treated more promptly, brought Maya back to the essential purpose behind all the institutional developments and educational initiatives. "That's what it's all about," she said with a smile. "Seeing what needs to be seen when it matters most." As the resident continued on her way, Maya reflected on the extraordinary journey that had brought her to this point. From being dismissed as too emotional to founding a center that would reshape medical education. From fighting to be heard in committee meetings to addressing national conferences. From having her clinical judgment questioned to seeing it validated and amplified across an entire institution. The next morning found Maya in her new office, a spacious room with windows overlooking the Seattle skyline. The walls were still bare, the bookshelves empty, the desk uncluttered. A blank canvas waiting to be filled with the work of the center she would build. Dr. Kim knocked lightly on the open door, carrying a small package wrapped in simple brown paper. "A housewarming gift," he said with a slight smile, placing it on her desk. Maya unwrapped it carefully to find a beautifully crafted wooden box. Inside, nestled in velvet, was an antique ophthalmoscope, the kind used by physicians in the early 20th century, before digital imaging and automated diagnostics. "It belonged to my grandfather," Kim explained. "He was a country doctor in Korea before the war. He used to say that his most important diagnostic tool wasn't his instruments, but his attention. His ability to see what others missed because they were too busy looking at what they expected to find." Maya lifted the ophthalmoscope carefully, feeling the weight of its history and symbolism. "He would have recognized what you've been fighting for," Kim continued. "The recognition that medicine is both science and art, that seeing clearly is as important as measuring precisely." As Kim left, Maya placed the antique instrument in a prominent position on her otherwise empty desk, a reminder of the lineage of physicians who had valued observational skills, long before they had a formal name or institutional recognition. Her computer chimed with an incoming email, the final design for the Center for Observational Medicine logo, which would soon appear on publications. curriculum materials, and the center's new wing. The design was elegant in its simplicity, a stylized eye within a medical cross, representing the integration of observation into the heart of healthcare. As Maya approved the design, her phone rang, Dr. Mehta calling with news that 3 more hospitals had expressed interest in implementing the observational diagnostics curriculum. The momentum was building, the ripple effects spreading beyond what any of them had anticipated. By midday, Maya found herself standing before a group of first-year medical students who had requested to meet with her after attending the conference. Their faces reflected the same mixture of curiosity and excitement she had seen in residents like Sharma and Wilson when they first began to understand the power of enhanced observation. "You're entering medicine at a remarkable time," she told them. "We're beginning to recognize that what makes a great physician isn't just scientific knowledge or technical skill, though those are essential. It's also the ability to truly see the patient in front of you, to notice the subtle signs that might not register on any test, but that tell the story of what's happening in the body." A young woman in the front row raised her hand. "Dr. Chen, some of us were wondering, how did you develop these skills when they weren't being taught? When the system was actually discouraging them by labeling them as emotional?" It was a perceptive question that went to the heart of Maya's journey. She considered her answer carefully. "I think I always saw this way," she said finally. "But for years, I tried to suppress it because it didn't fit with how I was taught medicine should be practiced. I tried to follow protocols exactly, to base everything on measurable data, to ignore the patterns I was seeing that didn't fit the established criteria." She paused, remembering the internal conflict that had characterized the early years of her career. "The turning point came when I realized that patients were suffering because I was ignoring what I saw in favor of what I was supposed to see. That's when I decided that being effective was more important than being conventional. That saving lives mattered more than fitting into the system's expectations." The students nodded, absorbing this perspective that ran counter to much of their formal education. "The irony," Maya continued, "is that what was once dismissed as emotional or intuitive is now being recognized as a sophisticated cognitive skill that can be developed and taught. What I was seeing wasn't less scientific, it was just science, operating at a level of pattern recognition that our conventional frameworks couldn't yet accommodate." After the students left, Maya returned to her office to find Dr. Winters waiting. Their relationship had evolved dramatically over the months, from adversaries to cautious colleagues to something approaching mutual respect. "The board meeting went well," he said without preamble. "Full funding approved for the center, including the patient partnership program you proposed." "Thank you," Maya said, genuinely appreciative of his support. "It would have been much harder to get this off the ground without your backing." Winters nodded, looking slightly uncomfortable with the acknowledgement. "I've been thinking a lot about our first encounters," he said after a moment. "About how quickly I dismissed your approach as emotional rather than seeing it for what it was." Maya waited, sensing he had more to say. "I've been in medicine for 30 years, he continued. "I've seen countless innovations, techniques, and approaches come and go. But I've never seen anything transform clinical practice as quickly as your observational methods. It's humbling to realize how wrong my initial assessment was." "It wasn't just you," Maya pointed out. "It was an entire system that valued certain kinds of knowing over others, that categorized some approaches as objective and others as subjective, often along gender lines." "Yes," Winters agreed, "but systems are made of individuals making choices. I could have chosen differently earlier." The acknowledgement was meaningful, not because Maya needed personal vindication, but because it represented the kind of reflection that real institutional change required. As the day drew to a close, Maya found herself back in the trauma bay, where her journey had begun. The space looked different now, not just because of the physical renovations that had accompanied the hospital's expanded emergency services, but because of the cultural shift that had transformed how medicine was practiced within these walls. Residents moved through the department with a different kind of attention, their assessments incorporating both standard protocols and the enhanced observational techniques they had learned. Nurses communicated their observations with new confidence, their insights valued rather than dismissed. Even the physical layout had been modified to support better observation, with improved lighting and designated quiet spaces for complex assessments. Dr. Sharma approached, tablet in hand, her white coat now bearing the insignia of chief resident, a position she had earned in part through her excellence in the observational diagnostics program. "Full circle," she said, gesturing around the trauma bay. "This is where it all started, isn't it? When you saw what everyone else missed in that multi-car accident case." Maya nodded, remembering the ethics committee meeting that had followed. The moment when her approach had been challenged and then unexpectedly validated. "I never thanked you properly," she told Sharma, "for speaking up during the review, for acknowledging what you'd observed in the Daniels case." "I was just following your example," Sharma replied, "saying what I saw even when it wasn't what others expected to hear." As they walked through the department, Maya observed the subtle but profound changes in clinical practice, physicians spending an extra moment observing patients before turning to their charts, residents discussing subtle findings that wouldn't appear in standard assessments, nurses empowered to report observational concerns without fear of dismissal. This, more than the center or the curriculum or the national recognition, was the true measure of what had been accomplished. A transformation in how healthcare was delivered at the most fundamental level. A recognition that seeing clearly was as important as any test or procedure. That the art of observation was not opposed to scientific medicine, but essential to its proper application. As the evening shift changed over, Maya prepared to leave for the day. In the hospital lobby, she paused before a newly installed plaque commemorating the founding of the Center for Observational Medicine. The inscription read simply, "To see what is in front of one's eyes requires constant vigilance." These words, adapted from a quote she had often cited in her earliest, most criticized papers on observational diagnostics, now stood as an institutional motto, a reminder of the principle that had transformed not just Maya's career, but the practice of medicine itself. Outside, the Seattle rain had given way to a rare, clear evening, the stars visible above the city lights. Maya took a moment to look up at them, remembering how often she had felt alone in her struggle to practice medicine the way she knew it needed to be practiced. She was no longer alone. What had begun as one physician's fight against mischaracterization had become a movement, a recognition that medicine at its best required both scientific precision and observational acuity, both protocols and the wisdom to know when they needed adaptation, both objective measurements and the subjective skill of truly seeing the patient in all their complexity. As Maya drove home, she reflected that the greatest victory wasn't the center or the curriculum or the professional recognition. It was the lives that would be saved by physicians who had learned to trust what they saw, to recognize the subtle patterns that preceded crisis, to notice the small signs that pointed toward diagnosis, to see patients as complete human beings rather than collections of symptoms and test results. What had once been dismissed as too emotional, her intensity, her attention to detail, her insistence on seeing beyond the obvious, had been revealed as exactly what medicine needed most: the courage to truly see, and the conviction to act on what you saw, even when others couldn't yet see it themselves. And in that recognition lay not just personal vindication, but the possibility of a medicine transformed, more perceptive, more responsive, more human. A medicine that valued both the science of measurement and the art of observation. A medicine that understood that sometimes the most important clinical skill was simply the ability to truly see what was in front of your eyes. Up next, you've got two more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out. And don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.